So yeah, let's get cracking. If anybody pops up and wants to add anybody in, then please do, because obviously I can only see what you can see. But we'll get started. Can everybody hear me?
Yes, we can.
Perfect.
Yes, we can.
Wonderful, wonderful, wonderful. I just wanted to, before we sort of start this case, just to sort of say here, obviously these are CTG teaching cases, but at the same time, as we say on a weekly basis, we are taking into account the whole clinical picture here. And I think that's even more important with this CTG today. So yeah. Okay, so this lady is a gravida 1 paranaut, age 39. She had no antenatal care in this pregnancy. She came to the UK 1 week before attendance in triage. This is something that we see very regularly at Croydon. So it's something that we reasonably prepared for. So a booking was thankfully done. I think after she'd actually delivered, but we managed to get majority of her history beforehand. She has a medical history. She has a BMI of 22, multiple fibroids, and the largest one was 10 by 10 millimeters. Sorry. She had an ultrasound scan in Ghana, 34 weeks and 1 day. There was no concerns. However, multiple fibroids were noted on the scan, the largest one being 10 by 10. I think there was lots of little ones as well, around sort of 2 to 3 sort of size. So she came into triage with SHROM at 37 plus 3. So at 7 o'clock in the morning, she's SHROM and she's transferred over to Hope Ward in view of her risk factors. With the women specifically that haven't had any antenatal care in the UK, we much prefer to sort of keep them, gain some additional information whilst they're there, because obviously, you know, different countries do things incredibly differently to the way we do them in the UK. And fetal monitoring is not something that's particularly prevalent in some countries as well. So Dawes-Redman criteria was met at 18 minutes, and this is your standard baseline. So you can see lots of fetal movements here. We've got a baseline of around 135, 140. I do see some accelerations and some good variability. She wasn't contracting at this point by way of what I can see from the documentation. So yeah, CTG was removed at 18 minutes. Personally, for me, this is purely personal preference. Part of our guideline for Dawes-Redman is that we can take it off as soon as the criteria has met. I think I'm just very anal about it, and I like to see a little bit more of the CTG before I'm fully confident, but this isn't something that you have to do. This is more so down to sort of personal preference, I guess. But yeah, if you're ever concerned within the first 15, 10 minutes even though it's met criteria, if you want to keep it on for longer, there's no reason why you can't or shouldn't. So she remains on antenatal ward. This is later on in the afternoon. So this is now around 6 o'clock at night. Criteria met at 32 minutes. Yes, it did meet after that deceleration occurred as well. The midwife that was caring for this patient reported that this was actually loss of contact. However, I don't know whether I would personally agree with that, and this could be argued as maternal pulse. However, due to the fact that it had stopped, this midwife did restart the CTG within a minute or two, as soon as that sort of had printed, and then as you can see again, this baseline had then continued on for, well, gone back to baseline and continued for another sort of 10 to 12 minutes before it was then removed. With this sort of situation, again, I don't know if anybody has any alternate opinions or anything like that. She'd had 32 minutes of CTG, which was normal until we got to this point. Note how she's got the fetal movement marker. That's also very, very, you can see lots of those like black lines there where this baby had possibly gone into a deceleration, but luckily had recovered. If I was the case midwife here, I would have possibly kept it on for a bit longer following on from this decel, and I would have escalated this to one of the obstetric team or the midwife in charge as well. But this midwife was confident after the following 12 minutes that this baby was fine, and so removed the CTG.
Just a quick one, Cara, just to ask
when you said she has fibroids, anybody told us where is the fibroid, or told us if the head is below the fibroid, or any details of that, or nothing at all? And if there is nothing, the admission to antenatal ward, has anybody put a scan on her tummy to know what is the situation?
No. So this lady didn't have an obstetric review prior to admission to antenatal ward. This was purely based off of the decision of the midwife. So I think it was a good call that we kept this woman in for monitoring and just to sort of gain a bit more additional information. But she didn't have an obstetric review while she was on the antenatal ward. So we didn't really know a lot about this baby at all, other than based off of what that scan said. So that one 10 by 10 millimeter fibroid, 10 by 10 centimeter, sorry, fibroid, as well as the other multiple little ones. But they were all, from what I can remember about reading this scan report, was that they were kind of scattered all very sort of high up on the uterus. There was none that were covering the os or anything like that, and none that were in the sort of lower segment area.
So from what I understand from you, it is the midwife is keeping her in to complete the booking and everything, because she has not been here in the country. That's it. So
Yeah,
kind of parking her till we understand. Is that right?
yeah,
Okay.
perfect. Mr. Nagib, just out of interest, whilst you're there, in this situation, would you have continued the CTG for longer after what looks like a deceleration there?
Oh, yes. Oh, definitely. Because it's not obvious what's happening. Yeah, of course. Yeah.
Thank you. Okay. So this is now later on in the evening. So this CTG that you see here is at around 6 o'clock in the evening. Night shift is now taken over. So at 2300, she was reporting pain around her fibroids, was offered some pain relief, however, declined this. At 23:45, she was increasingly distressed. It's documented plus 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 in the notes. They were unable to console this woman due to her pain, but also they offered her an examination and recommended a CTG. However, she kind of declined at this point due to her pain. She was offered pain relief again, but yeah, she just declined it essentially. Which obviously there's nothing we can do there to support if we've offered everything and she's declining it, then we can't do anything. On the 28th, so this is now just past midnight, so she's now, sorry, I think she's 37 plus 1, or 37 plus 2, sorry. At 10 past midnight, she was given dihydrocodeine and some paracetamol, which appeared to have worked. I think she was a bit more comfortable following on from that. And then she was able to be examined at 0032, whereby she was a fingertip dilated. She was given Entonox, and then 8 minutes later, she was given sympethydine with metoclopramide. So we've given her dihydrocodeine, paracetamol, Entonox, and pethidine, all in the space of half an hour. Once she'd sort of been able to settle herself and yeah, offer and accept pain relief essentially. Her observations, as you can see, these were from earlier on in the evening between the last CTG and this one. So these were all sort of within our normal ranges. Anyone want to comment on the first things they notice about this CTG in comparison to the last ones?
Raised baseline.
Yeah, absolutely. So we've gone from having a baseline of around 135 to now having a baseline of 160. So what are we going to do about this?
Sorry, Cara. Again, I'm feeling that I'm missing something here. Coming from Ghana for a week and suddenly lands in Croydon triage at 5 o'clock in the afternoon, and then suddenly starts having pains. I feel somebody sent her in. It's not a coincidence. It is too much of a coincidence to happen all together like this.
Yeah. I mean, she's also Shrom.
Oh, okay. Okay. Right.
So she's Shrom at 7 o'clock in the morning. So we're about I don't know, I can't think quick maths, but we're about 18 hours from now. So that's also taken into consideration the reason why she's been admitted, because of the fact that she's got all these additional risk factors and because of the fact she's had no previous care. We're going to keep an eye on the colour of the liquor as well, and also do some additional monitoring essentially for that.
Yeah. Now it makes more sense. So she's Shrom. I missed. Yeah.
Sorry,
Okay.
Mr. Nagib, I should have made that more clear.
Okay.
Yeah,
Thank
she's
you.
also Shrom. So we're now 18 hours Shrom. And this CTG continues on to the next page. It was 02:15 in the morning where CTG concerns were escalated to the midwife in charge and the obstetric registrar. This lady then had a cannula inserted, had some fluid started, and then at 02:38 she was transferred to labour ward with an abnormal CTG with D cells and tachycardia. Just a couple of things here. When it comes to sort of our women that have got high fibroids, I would personally recommend that we put a cannula in slightly earlier on, specifically when they're that sort of size, just because of the high risk of bleeding. CTG concerns, I'm glad they were escalated. I think we possibly could have done this a little bit earlier. However, good escalation, and then we did get round to labour ward reasonably quickly following from when we noticed that the fact that the baseline was slightly higher. The one thing that I want to add in here is if we've ever got an episode of fetal tachycardia, what we also really need to consider is maternal observations as well, because if we combine fetal observations as well as maternal observations, that can give us a much better overview of the overall clinical picture. So if we've got maternal tachycardia as well, we could be thinking, okay, yeah, dehydration. Possibly the need for fluids is much more necessary if she's dehydrated, if she's dry, those kinds of things. Hartmann's is definitely going to have an impact on that, which will hopefully then have an impact on the fetus as well. However, it's another case of, okay, we're starting Hartmann's with no particular reason for doing so, and we need to know more information essentially.
When you said it was escalated to the obstetric team, what did the obstetric team say?
The obstetric team said, let's bring her over to labour ward.
Okay. Yeah.
Which is fantastic. We didn't have any of your favourites, Mr. Nagib, where we review in half an hour and we don't give a specific time frame and what we're looking for in that period of time as well.
Yeah.
But we can
are
also
lucky. Yeah.
we can also see some decelerations here as well. Bear in mind, this woman is, well, an hour and a half ago or an hour ago, she was fingertip dilated. What is causing this baby some stress at this point in time if it's not progress? But she's contracting, as you can see, very regularly as well. Unfortunately, again, we've got no report of any contractions being palpated or any resting tone, or whether or not these contractions are true to the CTG. We get women come into triage all the time and they look like they're contracting 3 and 10 when sometimes it's purely Braxton Hicks, which can be a little bit strange when you're doing an antenatal CTG, but it's so important that we're palpating those contractions and we're documenting that as well. I cannot highlight that enough. Specifically with this woman as well, she's had fibroid pain. We want to know where that pain's coming from and how much that's affecting her too. All right. So she's now on labour ward. At 2:40 in the morning, she is given an ultrasound scan and this confirmed multiple fibroids. I'm sorry. None near the cervical os. Sorry, I don't know why my computer does this. Hartmann's is increased to 250 mils per hour at this point. So this is at about 3:05 in the morning that it's done that. And we've moved her to a left lateral position, I think in the hopes that these decelerations will then sort of disappear if they're due to cord compression. Baseline is sort of sat at around 150, but it looks like it's coming down a bit too.
And we are cephalic and
Yeah.
Yeah.
We are indeed. Does anybody have any comments that they want to add in here or anything?
And the head was in the pelvis.
The head was in the pelvis, yeah.
Right.
Perfect. So we continue. The obstetric registrar comes and does a review at 3:45 in the morning, and she is found to be 4 centimeters dilated. So she is moved to left lateral, and at 03:51 terbutaline was given. And as you can see, the CTG, well, the decelerations were nowhere near as frequent following on from that. So, Mr. Naguib, correct me if I'm wrong here, but terbutaline, we usually see the effects of between 2 to 5 minutes. Sometimes can take slightly longer, but normally the immediate effects of it will be within that time period.
Yeah. Yeah.
Perfect. Blood pressure is slightly raised at 132/87, which is obviously a bit of a jump up from where it was before, however, still sort of within our normal ranges. She has a pulse of 78, respirations of 18, SATs of 100%, and a temperature of 36.7. She was again offered pain relief at this point, but declined it. The effects of the pethidine are probably still working here, although we're not seeing a sort of stereotypical pethidine CTG where we do have a bit of reduced variability for a while. Which is very, very common and something we really need to consider when we're looking at the overall clinical picture. And our baseline sort of settling back down to what it was previously, which is around 135, 140, which is positive too. Mr. Naguib, would you have given terbutaline here?
I would. Yeah.
Perfect.
Where is the head?
I think the head was -1.
Okay. Yeah.
Perfect. So as you can see, I would personally call these chemoreceptor decelerations. If anybody has disagrees, then please do let me know. But due to the fact that there's very reduced variability within the deceleration, and it looks like their recovery is after the contraction here, specifically the one that you can see sort of below my big blue box in the middle, we are coming back to baseline and in between those contractions, which is good, and the variability between them is normal. However, just due to the fact that these are sort of reduced variability within them and they recover later than that contraction, I'd go with chemo. However, our TOCO is not particularly great and working very effectively at this point, so we can't see it very clearly. Again, maternal contractions, making sure that we're palpating them is going to really, really help us in these kinds of cases to make sure that we are correctly identifying what we're seeing on the CTG, specifically with decelerations as well. But yeah, I cannot stress that enough. But it's sadly something that we don't document very frequently. I'm doing my best to try and make it a compulsory factor on Cerner so that people have to do it, and it jogs people's memories for it as well. But yeah, just to sort of highlight that, please do escalate that out to everybody when you're working clinically. Okay, so we'll continue. CTG, as you can see, sort of settles here. Her contractions are very much spaced apart, so we're going more with sort of the 2 to maybe 3 in 10 here, and the TOCO's picking them up much more clearly. Our baseline is still nice and stable, which is good. And we've got the odd baroreceptor deceleration in there as well. Maternal pulse is palpated at 89 beats per minute here too. And it looks like we've got an acceleration towards the end in the last sort of 5 minutes of this segment as well. So whatever we've done with that terbutaline has definitely had a positive impact on the care that we're in the case. So this is the next bit. So the CTG is reported as normal. Our baseline is still nice and stable. We've got some baroreceptor looking decelerations. We've got some shoulders with them as well, which is great. These are all positive signs that baby is coping and compensating well with the stress of those contractions. And we're returning back to baseline with good normal variability here. So we continue. It's now 1:40 in the morning. Sorry, it's not 1:40 in the morning. It's 5:50 in the morning. We've still got good baseline. We've still got good variability. We've got some accelerations. Doesn't appear to have any decelerations here either. Although this client did start vomiting at around 18 minutes past 6 in the morning. It says ++. I don't think it was measured, but then she went out to the toilet at the end of the CTG and she passed 100 mils of urine. Bearing in mind she's probably had at least a litre of Hartmann's by this point. I'd probably expect a little bit more urine when it comes to our fluid balance. This is another key message to take away from this, is how important it is that we're measuring this. But yeah, just to take that away from this case today as well. It's super important that we're making sure that our women are passing urine and drinking oral fluids as well as being hydrated with that Hartmann's. So we continue. She still has no pain relief on board. We've got paracetamol and dihydrocodeine that was given again at about 6:45 in the morning. Nice variable baroreceptor, deceleration there. And our baseline still remains stable with some good variability here as well. Possibly some cycling as well, just as it's slightly less variability than it was in the previous CTG. So these are all reassuring signs that we've got a well-compensated fetus. But her contractions have also very much spread apart here to sort of 1 in 10 at this point. This continues. Pink liquor is now noted. Also bear in mind that this lady is now prom. So just thinking about that in the back of our minds when it comes to considering infection risk and whatnot. All of the observations that were taken on mum are recorded on the CTG. So just to take that as well as a key message from this, the importance of doing regular observations. We haven't done any for quite a long period of time now, a good over 4 hours, other than that maternal pulse that was palpated about 2 hours ago. So just making sure we're going back to the guideline if we're ever concerned or we ever want to remind ourselves of how frequently those need to be, but we need to be doing them a lot more frequently than they were done in this case. Sort of routine care, we need to make sure we're doing a blood pressure at least every 4 hours, as well as respiratory rate and temperature. Even more so with this patient due to the fact that she's now prom. So we may see the signs of infection possibly with mum before we see them in baby. This is me being overactive with it, but yeah, just something that we need to be very much aware of. And her contractions here are reported at being sort of 1 in 10. So definitely died down from where they were previously. Anyone want to do anything at all at this point? I'll take that as a no. We continue. At 8:15 in the morning, she is examined and she's made excellent progress to 7 centimeters dilated, despite the fact that she's only contracting sort of 1 in 10. And her obs are now done. So blood pressure 120/81, pulse of 78, resps of 18, and a temperature of 36.6. As we can see, this baby has responded beautifully to the examination. So we want to see that fetal scalp stimulation that we get a response from on the CTG. And we're seeing some lovely cycling here as well, whereby we've got some increased variability followed by a period of slightly more reduced variability. So babies, everything is working effectively with this baby at this moment in time. She's moving different positions now, so the day team have taken over. So we've got nice fresh midwives that have started. Blood pressure is raised again, gone up to 143/83, pulse of 69, resps of 17, oxygen sats of 98%, and a temperature of 36.6. Couple of baroreceptor decelerations here with those contractions, but not concerning. We've got some beautiful shoulders on there. So this is a non-hypoxic CTG and our baseline still remains nice and stable with good variability. This continues. I think it goes on like this for a little while, guys, so just bear with me. Bloods were taken due to the fact that we've now noticed at this point that this woman's virology hasn't been done as part of her booking bloods. We just did the purple and the pink bottle just to get those things, but we haven't taken a virology for this woman. Obs, as you can see, completely normal here as well, and she's well she's feeling well in herself, just with she's obviously still not got any pain relief on board, but she's well and she's comfortable at this point, coping well with her contractions. We continue. At 10:50 in the morning, the CTG is reported to be gradually evolving hypoxia, which is compensated. The cervix is re-examined at 10:50 and is found to be 7 centimetres dilated. So unfortunately, she's made no progress, although kind of to be expected considering her contractions are very much spaced out. At 10:55, they do the ward round. The labour ward registrar is present at this point, and the plan is to administer butylene if another deceleration occurs. Bloods, as you can see at the top here, HB133, platelets 305, and a white cell count of 10.8. What are our thoughts now?
I do not understand that plan.
I agree. There is no. What is the point in giving more terbutaline when the CTG is near normal, and what is the point in slowing down more the labor? I would rather, if I'm really trying to make a car crash and finish it off, rather than giving terbutaline, section her. You know, why are we making an excuse now? There is no need for terbutaline here.
I did think the same thing. Can I just ask, would anybody be happy to start Synto on this CTG? Considering she's now 4 hours no progress, that's our typical next step. Would anyone be happy to start Synto?
Is there any sign of obstruction on VE?
No.
CTG would not be what would keep me from starting Synto. I'm generally speaking on the careful side of starting Synto at 7 centimeters plus, just because there are enough trials by now out where you can stop Synto at 6 centimeters and probably just continues. So why starting it? So she was never contracting terribly much and made progress, no, from 4 to 7, and only 1 by the looks of it, 1 in 10. So why would it hold now? So I would be very careful and looking for any sign of obstruction, but I would otherwise consider giving her a trial of Synto. The CTG wouldn't stop me from doing that. Yeah.
Dagmar, what was that you just said about the research you've read about 6 centimeters plus and stopping Synto?
Oh, there are when was it, in 2019, the first European perinatal guideline about use of syntocinon was published. That's the very first guideline about syntocinon overall. And they essentially kind of phrased for the first time a caution in starting it when you're in active labor. And then there is the question, when are you in active labor? And England still uses the 4 centimeter from Friedman, whereas the Americans say 5 to 6. But they see, actually, there are by now more reviews that say active labor is 5 to 6 and not 4. And then you have to ask yourself, in a spontaneous onset of labor where you didn't give anything, why would progress then out of a sudden halt, particularly if you're in the active phase? So why would you then need to start it? And then the answer is that you should really be very carefully examining for any sign of obstruction and not missing that, and not just starting Synto for the sake of starting Synto. Yeah, that's the kind of rationale behind it.
No, that makes total sense. Dagmar, if you're happy to, would you be able to put a link for that in the chat?
It's not only so the European guideline you can't access. You need your account, so I can't forward it, but I can send you the link to the kind of European guideline. Yes,
that would be great.
And regarding the review for stopping syntocinon at 6 centimeters on all of the induction of labor, yes, I would find the link. I would have to look for it, but yeah, I can.
Thank you very much. Perfect. So we then continue. Blood pressure is now normal, 122/86, pulse of 78, rests of 17, temperature of, that's the wrong way around, SAS of 98 and a temperature of 36.6. Terbutaline was given here for the second time at 11:15 due to the decelerations. They had to move rooms to get the patient on central monitoring. So they did that quite quickly, actually, between sort of 11:32 and 11:37. At 11:37, they had said that there was a prolonged deceleration on transfer, followed by another prolonged deceleration. So moved to left lateral. Now there's no CTG between 11:32 and 11:37. So that's a period of 5 minutes that we've supposedly had 2 prolonged decelerations. I know my maths isn't fantastic, but that doesn't particularly add up in my head. And
sorry, Cara. On transfer to where?
On transfer from room to room. So I think she was in one of the rooms that doesn't have central monitoring, and then she was moved to a room that did have central monitoring so that they could see it from outside, because there was increasing concerns with this CTG. So she was given terbutaline at 11:15, and then at some point between, in the space of 5 minutes, when she doesn't actually have a CTG connected, there's supposedly a prolonged deceleration.
Cara, I'm quite concerned that we're giving terbutaline for this deceleration that we can see on the screen.
Yeah, so was I.
I mean, we have to kind of like maybe, I mean, CTG teaching should be enough, but like we are jumping too much on terbutaline. I know we like it, but this is a little bit too much. And I can see that the baby, it's a perfectly normal CTG. So I'm not sure. Am I missing something?
You're not, Maya. And this is one of the reasons I've brought this to the teaching today, because I'd love to hear if anybody has an opinion where they think that, you know, they think that the plan of care or disagrees with what we're saying. To me, this CTG shows no signs of hypoxia. If you want to get proper physiology about it, this baby spends so much time at the baseline that gas exchange we know is going to be working effectively. We've still got accelerations present. We've got beautiful variability, and the baseline remains as stable as it was the second she first went on a CTG monitor, which was well over 24 hours ago. So in terms of these decelerations, this one in particular only lasts a minute and 15 seconds maybe, or maybe a minute and a half. They also put up more fluids at this point as well, and the rationale behind fluids for this situation, I'm a little bit lost. So
we are all lost. We are all lost. Yeah, we are all lost because we were thinking of Sinto, which is the positive side of the contraction. Suddenly somebody gives terbutaline to go to the negative. So you have neither left us in the zero stage, but you got us backwards.
We're going minus. Yeah,
we are going minus. So and on what basis, really? Except if you are, I'm thinking here more or less. I like to go deeper into the brains of the people acting.
Yeah.
Except if the person acting here is trying to make it fail, to take her to theater ASAP to finish the story. But I mean, you can do that without making an excuse, really.
Yeah. No, absolutely.
But you know, Cara, surprisingly, neither the baby nor the mom are feeling the side effect of terbutaline. So neither mom is having tachycardia nor the baby.
No.
And they have two. So
yeah,
the baseline is that stable, that not even showing side effects, you know.
Yeah, which makes me think even more. There's no hypoxia here. There's no issue with this CTG. There's no issue with this baby, and there's no issue with this mother. I don't know if at the back of our minds, obviously with this case, I don't know whether or not the fact that we've had no antenatal care is causing anxiety, which I can totally understand. The thing for me as well, which I think is so important, and I've said this already 3 times, and I'm going to say it again, although we've got on the TOCO here, we're not seeing any contractions, or we're seeing very limited sort of uterine activity. We've got no report of how frequently this woman's contracting, because we've got no record of whether or not the midwife, the obstetrician, the student midwife, anybody has actually palpated this woman's abdomen. How many times do we see it where women are contracting 3 and 10 and the TOCO isn't picking it up, or vice versa, when they're contracting 3 and 10 and we can't actually feel them at all? The importance of using our hands and doing things manually here is one of those things where I just have to highlight it and highlight it and highlight it, because actually this woman's coping beautifully with the pain of contractions. You know, she's had hydrocodone and paracetamol and is coping really well with it, but we're not actually recording how frequently these contractions are happening. So this woman, for all we know, as an outsiders looking in, could say that she's not contracting at all. But if we were there at that moment in time, we could actually be palpating 2 to 3 contractions in 10 minutes. But we're relying too much on this
Also,
technology.
yeah, another one. How did we note the deceleration on transfer? Have we been listening in the corridor, like while we're moving? Can
We
you
don't have any.
clarify this?
No, I wish I could, Mr. Naguib, but I can't
Because
clarify it because we don't have telemetry. So we wouldn't have
because
been able to
yes,
hear it in the corridor.
no. So this 5 minutes that we are talking about the deceleration on transfer, and it's not recorded in front of us, and we can't see the deceleration. So who is saying this kind of things? Like it is like possibly somebody listening with a sonic aid while the bed is moving, or again, there is things that we don't understand in this, but anyway,
Mm.
fine. Let's continue. It is becoming slightly like a action film.
Mm. So at 12 o'clock, a third terbutaline is given and pre-meds are now administered. The consultant is present and this lady is consented for a category 2 cesarean section.
And the indication is
The indication is CTG concerns. One thing from this that I will say,
Actually, with the saltatory pattern, I do agree.
yeah, the
uh,
thing,
I personally don't think it is. Like this saltatory has not gone for long enough to
yeah,
suddenly.
I wouldn't call it saltatory. I would call it zigzag, but zigzag pattern
Yeah,
is essentially acknowledged if it's only 1 to 2 minutes long.
yeah.
And if it's I do agree that the kind of old school used to be 25 minutes. I think that what you were referring to, Mr. Naguib.
Yeah.
But yeah,
I, I,
the
I feel the zigzag that we are used to, Dagmar, is not this. Is this is the baby has been telling me I am absolutely fine all the way for the last 3-4 hours,
and
and we
cycling.
keep giving and cycling, and we keep giving terbutaline as if we are on a rat test dose. And I don't know, the baby maybe is reacting to the kind of terbutaline that is accumulating in his or her body and just becoming crazy. But I don't know. Yeah.
I have no idea. I don't tend to give Terbutaline 3 times, so therefore I don't know what
No,
babies
I
look like then.
yeah.
Yeah.
Yeah. I,
The-
I
the th-
don't I don't personally give terbutaline more than 2 times in one labor. I never gave 3 terbutalines in this way. So I'm again very perplexed with the way we are thinking, and it makes me think it is really I don't know. Fine. Okay, let's continue. I am intrigued.
I'm thinking of all of the research I've read recently, and we've started teaching physiology as the main point for teaching at Croydon now, as we're moving and we're changing over guidelines. When it comes to physiology here, what goes on in my head is the fact that when you look at all the research done and we look at sort of baroreceptors versus chemoreceptor decelerations, baroreceptors we know are very physiological, they're very mechanical, and so as long as we've got good variability and a good baseline and stable baseline in between our decelerations, we know that this baby is well compensated and non-hypoxic. The same thing goes for a chemoreceptor deceleration. So even though we've got reduced variability within the decel here, and they are recovering well after the contraction has ended, and they are chemoreceptor decelerations, we've still got a completely normal baseline where perfect gas exchange is occurring and normal variability between those contractions here. And even to an extent that they almost are baroreceptors, because they've actually got shoulders to them too, or at least beforehand. And we've seen cycling throughout the last pretty much 12 hours of CTG. Yes, okay, the sort of zigzaggy looking pattern is something that we're going to keep an eye on, but it's not something that we would necessarily say, okay, this is needing an immediately transfer. And I think I'm right in saying this, but saltatory pattern, for it to be technically classified, if you want to be super specific, has to have gone on for a period of 20 minutes before this is the case. So I look at this and I think I don't think this baby is hypoxic. But yeah, we'll move on. At 12:47, we left for theatre. At 12:50, she came back into the room because there was another emergency that was more urgent that needed to go to theatre first. And then we were taken back 9 minutes later. Anybody want to do anything additional before we go to theatre, just out of interest?
How about examining
Has
her?
she had another VE?
No.
Examine, and Cara, how are we doing bladder care in this lady?
We're not.
Oh, we're not.
She's not got a catheter. She passed 100 mils of urine about 4 hours ago.
Okay.
I think I've got a theatre. Yeah, okay. So we're now in theatre. 13:16, a spinal is put in, followed by a bradycardia. So this case was then converted to a category 1 emergency cesarean section. The emergency bell was pulled immediately. At 13:23, we had knife to skin, and at 13:26, we had knife to uterus and delivery. This was confirmed as being the fetal heart rate, but interestingly, we've got no maternal pulse ox on here at this point. So we've got an acute hypoxia, probably due to the bradycardia here.
Yeah, but that's caused by us.
Yeah,
100%.
exactly.
Like this is all caused by us.
Yeah. Anybody want to guess the outcome of this baby?
It will be something acute, so something like 722, 712 with normal upgards.
So this baby went into acute hypoxia at 13:11. Is that correct? I can't see it. Okay, and it was delivered at 13:26. So you tell me 15 minutes.
Yeah.
Well, if there was no kind of improvement, and given that the heart rate was below 80, then that will have impacted the baby. So 15 minutes, 0.01 every 1 to 2 minutes of fall. If it was previously 107.25, then it will be 7.1. So therefore, might require a little bit of initial resuscitation and then should perk up. But yeah, should still not be significantly acidotic.
I'm going to guess 5 inflation breaths for the Apgar and for the pH 7.1, 7.12.
Perfect. Well, I'll put you out of your misery. This baby had APGARs of 2, 6, and 7. This baby had a venous pH of 7.18. I mean, these are the same vessel, aren't they? I think they're probably arterial. Base excess of 8.5 or 8.9 and a lactate of 10.2. This baby was shocked with a heart rate above 100, but no respiratory effort, so he required intubating for oxygenation. This baby was also very, very little, on the 0.4th centile, weighing 2,375 grams, which is the sort of thing we would probably expect from a baby of that small size, following on from an acute hypoxia. I should note he was extubated very, very quickly after being transferred to the neonatal unit, and returned to mum, I think, just over 12 hours afterwards. But yeah.
Regarding the 0.4th centile, we are 100% because she's a late booker. Are we sure of our dates as well?
No, I mean we're going by the dates that were, well, essentially
so she's someone
from
who's
Ghana.
not. Yeah, she's not booked with us. We have absolutely no antenatal care, so I think we don't even know if this baby's a preterm, isn't it?
Yeah.
So I mean, I can understand the lactate and the respiratory problem, but the 0.4, because this baby wasn't behaving like an IUGR baby.
No,
So this
not
is
at
like
all.
I'm more like going to doubt that we got the centiles and the gestational age wrong, rather than actually this is an IUGR baby. It didn't behave like one.
No, I know.
I am with Maya here. I do not know practice in Ghana, and I can't comment. I only know it from Ethiopia, where at every scan that you have in your antenatal care, the due date is set anew. That is essentially how it works. And so you literally put it each and every time on the 50th percentile, and then you essentially make up a new due date. That is how it works in Ethiopia, i.e. you don't believe it. You go by the very first scan. The principle that we have in England, I think we should never forget, was branded by Professor Nicolaides, who was in his making it a general guideline for dating in the first trimester, white, ahead of his time when that was introduced in England, and coming from Europe, it's still not practiced there either. So yeah, I'm with Maya.
Perfect. Does anybody have anything else that they want to comment about this case at all?
I have only one comment. It's not related to the CTG really, and I kept asking maybe the same question multiple times. Maybe laboring on a fibroid uterus needs careful ways of dealing with it in obstetrics. The fibroids, and maybe it will be difficult for our colleague midwives to understand fully how the fibroids are done during myomectomy and how some of the fibroids are holding the uterus down and holding the uterus left and right, and in some situation with a cesarean section when there is fibroids, the baby might be the head might be below the fibroid, but the shoulders are above the fibroid. That's why this kind of labor should have been carefully seen by a senior obstetrician, not as CTG, not as dilatation, but as relation of the body, of the head to the fibroid, relation of the cord, putting the, even myself who is not fantastic in scanning, I can put the color Doppler and see where is the cord? Is it below the head? Is it above the head? You know, give myself a bigger prospect of looking into the baby in relation to the fibroid. Terbutaline with fibroid uterus doesn't contract sometimes fantastically well, and with fibroids, I appreciate what Maya said about bladder care. We need to be very cautious that some of those fibroid uteruses can make the bladder chronically distended in women even without a baby. So sometimes these bladders can cause like slowing down of the labor. So I mean, it is beyond the scope of the CTG teaching, but this labor has not been managed obstetrically in the right way and giving me enough information to be satisfied that we attempted to give this woman a vaginal delivery if this is what she wanted. I'm not really pro or against, but again, we are just doing anything that comes to our mind without any speculation of the contractions of the fibroid, of the liquor, of a shrom on a closed cervix and terbutaline and so on. So yeah, I feel like it is a bigger thing than just a CTG. Fibroid uterus needs a skill in managing labor, especially with 10 by 10. I need really, really, really to be 100% sure where is this 10 by 10. Yeah.
For sure. Perfect. Thank you, everybody. Thanks for everyone's contributions. I've got another really good case next week, so I really hope to see you all there again. But yeah.
Cara, the two references
Very interesting.
Cara, the two
you.
references you asked for are in the chat. All right.
Amazing. Thank you so much, everyone.
Thanks.
Thank you.
Bye.
Thank you so much.